Donc là, on va montrer un petit peu l'expertise locale de Montréal avec Dr Ladouceur, qui est aussi donc MD, PhD, et qui est une grande rhumatologue à McGill. Elle est allée se former après à Bordeaux. Et les rhumatologues, je dois admettre, là, puis mes collègues oncologues, ils sont bien en avance sur nous parce qu'ils ont un très beau registre pan-canadien sur les toxicités de la rhumatologie en oncologie, chose que les gastro n'ont pas, les cardiologues n'ont pas, les pneumologues n'ont pas. Et donc, on est jaloux de la rhumatologie et vous allez nous montrer tout ce que vous faites d'extraordinaire. Merci beaucoup.
Thank you for this opportunity of speaking today. And my talk is a bit more clinical, so I hope for just the end of the morning before lunch, bear with me, and I hope you're going to have some key points you're going to be able to apply in the clinic after this presentation. So those are my disclosure. So I decided to talk about ICI myositis, which is one of our most severe rheumatic complication from ICI, as well as ICI arthritis, which is the one we see the most frequently. And again, at the end, including a little portion on safety and efficacy of patients with rheumatic disease, which are going to be started on ICI. It's something we see more and more in the clinic. So just before getting started, a little reminder on potential mechanism of ICI toxicity. There's, like we discussed before with all those previous talks, there's activation of self-reactive T cells and B cells. There's potential shared antigen, and this is what we see in myositis and myocarditis as well. So this was well described earlier on. There's antibody-mediated toxicity, like just our patient partner discussed this morning with the hypophysitis. There's also a potential impact on T-cell regulators, and there's cytokine changes in the role of microbiome, and genetic factors, which we see also in ICI arthritis, which patient that has a certain type of HLA DR4 are more at risk of developing ICI arthritis. So I'll start with ICI myositis with a clinical case. So Mr. K, he's a 70-year-old man with laryngeal carcinoma that was initially treated with surgery. A year and a bit later, developed local recurrence and was treated with carboplatin chemo, pembro, basically a combination chemo immuno, and he received one cycle. And I think this is important because when we discussed the mortality of myositis and myocarditis, I think we got much improvement in terms of safety when we are doing the blood test prior to the next cycle. So this patient got his blood test just prior to cycle 2, which showed increased CKs in the 3000, TROPS-T 4000, TROPS-I 286. But the patient was totally asymptomatic. And I think before we used to miss those patients and maybe get them later on, and now we're able to capture them much early. So epidemiology of ICI myositis is a rare complication, mostly 0.4% of patients that are treated with ICI. It's mostly with PD-1, PD-L1 more than CTLA-4. Combination carries a higher risk than monotherapy. We see it more in male and older patients, and we see it more commonly in melanoma and lung cancer. But we discussed earlier the specific case of thymoma, which is a rare cancer that carries a specific increased risk of developing myositis. As discussed earlier, again, there's a median delay is very short. So between the initiation of ICI and myositis, it's the median time is 21 days. The patients will mostly present with weakness, myalgias. We see it more of a proximal pattern. There's also axial and ocular and bulbar involvement are the muscle involvement that we see most frequently in the clinic. The severe disease, this is what was discussed, like the myasthenia gravis-like symptoms, and I'm glad I removed all my slide about this controversy because Dr. Salem really well explained it earlier, where we think it's mostly more myositis of the bulbar and ocular muscle. Whether it's myasthenia gravis or not, we know that it's associated with a more severe disease and carries an increased risk of mortality. There could be some sign of like rhabdomyolysis in the most severe cases, and as opposed to our pre-existing myositis, there are usually no rashes, no ILD associated, except when it's paraneoplastic. And the pathogenesis, it's T-cell driven. So we have our pre-existing dermatomyositis, which more include a B-cell, but here we see in the muscle biopsies autoreactive T-cells and some cross-reactivity with muscle-specific antigen that is found both in the tumor and in the muscle. So in terms of investigations, we look at the CKs. Sometimes rarely we can have normal CKs. So aldolase, it's another enzyme we can request when we have a high suspicion. The LDH, the hepatic enzyme, the anti-acetylcholinesterase antibodies. And we also do the whole workup to rule out concomitant myocarditis with the TROP-I, TROP-T, BNP, and we always request the serologies for rheumatic disease, so ANA myositis panel. They're often negative, but we recently had cases where we in fact unmasked some pre-existing myositis rather than having a de novo ICI myositis. So it's always important to keep this in mind. On the EMG, we'll find myopathic changes. On the MRI, we can see, and we often ask the MRI of the region which is affected. So if it's more the shoulders or the hip, we often gonna ask the MRI of the girdle, and we see edema, which is compatible with inflammation. And on the muscle biopsy, it's not always easy to differentiate from a pre-existing myositis with the ICI-induced myositis, but we'll see some differences where we're going to see more the endomysial infiltrate as opposed to the perimysial T cells and macrophages as opposed to the B cells, and there's going to be often we see necrosis. And as very well explained by Dr. Salem, we always ask for MIPS and MEPS to screen for respiratory failure. And there's an important differential diagnosis. As we know, the patients with ICIs can develop other immune-related adverse events, mostly endocrine, which can also manifest with weakness, increased CKs. So hypothyroidism and adrenal insufficiency always have to be screened when we see a patient with similar symptoms. In terms of, we have our colleague who's going to present on neurological manifestations, so Guillain-Barré syndrome and all the peripheral neurologic disease, encephalitis, can also present similar way as a myositis. And in rheumatologic disease, we have our paraneoplastic dermatomyositis, which can also be exacerbated with ICI and could be treated differently. To make sure the patient is not on a statin, because we saw cases of statin-induced myositis and anything that's also metabolic or prolonged immobilization that could increase the CK. So we saw once a woman, I'm just looking at Dr. Friedman, which she was found 4 days after being after a fall, and she had high CKs, and I think maybe most likely she never had myositis, but it was mostly high CKs from her prolonged immobilization. So always have the differential diagnosis in mind also when we see patients. So in terms of treatment, the first line is still, to this day, the corticosteroid, which has a broad effect on all the immune cells. When we're not able to taper, it's refractory. When we have time, we've used cells, mycophenolate mofetil in some cases, but it usually takes time and action. So it's rare that we use those lines of treatment like methotrexate or mycophenolate mofetil. They could be effective, but really it has to be something that we're not going to give necessarily immunotherapy because they don't act very quickly. We have used abatacept in those very, very severe cases. There's cases reporting anti-IL-6 and anti-TNF as well, IVIG, pheresis, and there's a recent increased interest in studies that show the efficacy of the JAK inhibitors. Then I will go more in details into that. So as we know, yes, steroids act quickly, they have a very broad effect, but we have to be careful because they could potentially be, there's a bunch of side effects, but also on the ICI efficacy. So something that many studies have suggested is that the timing of corticosteroid administration is important. When it's early on, some studies some studies is 1 month, others 2 months like this one, but when it's given early on after ICI initiation, it blunts the efficacy of immunotherapy. So sometimes we don't have the choice. When the myositis occurs very early on, it's severe, we have to treat it. But for some other manifestation, like I'll talk later with arthritis, when we're able to delay a little bit the initiation of steroids, we do it because we think that when the immune system is being primed at the initiation of ICI, this is where the efficacy takes action, and we'd like to not blunt this effect. So in that study, there was a clear difference in overall survival in those that were receiving steroids in the first 2 months of ICI initiation. And there's also an effect of the peak dose and not the cumulative dose. So for IREs, when we and other indications like metastasis, or just to give them more, like those that have no energy, that they need to be on steroids, or even given with the chemotherapy, the higher dose is associated with the reduced survival and reduced progression-free survival. So we always try to be at the lowest dose possible, and this is what we'll discuss later when I talk about the arthritis. With the myositis, often when it's urgent and we need to treat, we still are sometimes pausing the patients here and giving high dose of steroids. But when we have time to treat the patient, we better start low and maybe increase, because the peak dose has an effect on ICI efficacy. And now, what about the DMARDs and the biologics that we can give in myositis or in arthritis as well? So this is a study on arthritis, but we still use those conclusions when we treat any rheumatic or other adverse events that we see with ICIs. So they compared methotrexate, anti-IL-6, and anti-TNF. So for those who are used to use methotrexate, maybe with the patients that have arthritis, or it takes a long time to be effective. So for sure, the time to control the disease will be longer. So if we have time to wait, we can use it. If we are more in a rush to get the patient either like better or back on his immunotherapy, then we would be better to use the biologics that act more quickly. In this study, there was maybe a signal on a lower progression-free survival with anti-TNF compared with anti-IL-6. So that's to be kept in mind. But the conclusion remains that it's better to stay on the ICI. So if to use those that are more effective quickly to control the IRE, and then allows to go back on the ICI. And now, what about JAK inhibitors, which are recently started to being used? So there's a dual effect on the JAK-STAT pathway regarding the tumor. So if we have a loss of the JAK-STAT pathways, it's associated with resistance to ICI. And on the opposite, excess JAK-STAT signaling can lead to cancer, immune evasion, and autoimmunity. So I won't go back to this paper, which was presented, but this was the first one that suggested that JAK could be very useful in treating IREs with the ruxolitinib. And there's, after that, other papers that were published, so that use several JAK. So this retrospective study on 104 patients, they use tofacitinib, ruxolitinib, baricitinib, upadacitinib, and the indication were various, so mostly myocarditis, myositis, hepatitis, and they all had failed prior treatment, and they showed that there was a IRE resolutions in most of the patient or clinical improvement, and with a good tumor outcome. And there's two recent papers that were published in Science in 2024 that looked at combination JAK inhibitors with immunotherapy. So there's one paper with refractory or relapsing Hodgkin lymphoma. This was a phase 1 study that combined ruxolitinib and nivolumab in Hodgkin lymphoma that were refractory to immunotherapy. And there was a complete response in 6 out of those 19 patients that were refractory initially, and 4 had partial response. 1 needed transplant, and the progression-free survival was 46% and survival 87% at 2 years. So those are encouraging data suggesting that we can use JAK inhibitors combined with immunotherapy. And then there was this other paper that used JAK1 inhibitors in non-small cell lung cancer that were treatment naive. It was a phase 2. The pembro was initially given for 2 cycles, and pembro with itacitinib, which it's a JAK1, and then pembro until progression of the disease. And when compared, they didn't have a control group, but when compared with what was published in the trials, there was a very good overall response rate and progression-free survival. And finally, one study from our group, because we have used JAK inhibitors for our severe and refractory IREs. So it was recently published, which shows that is effective and also safe in terms of cancer response in patients that had a median follow-up of 254 days post-JAK initiation. And most the one that was the mostly used was tofacitinib in that case. And there is myositis in our cohort. It just there was they're merged with the myocarditis group. So the patient, remember, he was asymptomatic, but that had very high CKs and TROPS-T, TROPS-I, so he was sent to the emergency, because even if he had no symptoms, this is something we have to take on very seriously. The EMG was normal, the MRI of the girdles was compatible with myositis, although we didn't have any weakness on physical exam. The cardiac echo and the MRI was normal, and as was demonstrated this morning, this is still possible to have myocarditis with a normal imaging, and the myositis panel was negative. So he was treated with pulses of salomedrol and prednisone that was quickly tapered. So as opposed to our rheumatic disease, where we usually do a slow taper, with IREs, we usually try to taper rather quickly. The ICI was obviously discontinued for this case, and his cancer was in complete response, so he was switched to chemotherapy. The prednisone was tapered, he had no myositis or myocarditis relapse. However, in June 2024, he had a local recurrence. So the question was, should we re-challenge or not this patient, and that had previously had myocarditis, myositis. And as discussed earlier, because this is one of the topics that's really up to date now, the re-challenge, we don't have much evidence regarding this. So it's mostly retrospective data. In that study, there was 20 patients with ICI myositis. 9 of the 20 were re-challenged. 6 out of the 9 had prednisone coverage. 1 had prednisone plus methotrexate and IVIG. None of the 9 flared. So it seems, I think they had well chosen their case maybe to have like no flare, but it didn't seem like the ones that were not covered by any immunosuppressive at the time of re-challenge were at the increased risk of flaring from this little small study. And the prednisone, for those who were on prednisone at ICI re-challenge, it was able to be tapered in less than 100 days. And then there was this other retrospective cohort study of 36 patients. There was only 5 patients that were re-challenged. They all had resolved their myositis prior to re-challenge. and only one flared. So, and he had a severe overlap syndrome. We don't know if they were covered by immunosuppressive before. So the problem with all those retrospective studies is we're lacking some information and not able to translate it also to our clinical challenges, because we don't have all the information, and there's also bias in the publications of those cases as well. There was also 2 out of the 31 that were not rechallenged that had flares. So we can also flare without having a rechallenge. That's why we will also follow our patients carefully even after they have stopped their immunotherapy. So we had a big discussion with the patient, and he had no other option. His cancer was very close to the carotid, and he was not responsive to anything, not amenable for surgery. So accepting the risk, we all decided to re-challenge him with chemo and pembrolizumab. And a month later, he developed a prednisone refractory myocarditis flare, but not the myositis flare. And then we added tofacitinib. So he's part of the cohort that we presented. So this is the kind of the how we use the JAK inhibitors in our practice at our center. And the myocarditis was under control, but unfortunately the cancer progressed, and the patient was transferred to palliative care and passed away. I'm going to talk about inflammatory arthritis, which is the most frequent manifestation that we see in the clinic. And I'd like to say that not every new pain that you see in a patient that you start ICI is arthritis. So we see a lot of osteoarthritis that can have activated osteoarthritis, tendonitis, capsulitis. And I think this is very important to see the difference, because as we discussed, the corticosteroids and all the immunosuppressive can be deleterious in terms of cancer response. So if we treat the patients with mechanical pain with those treatments when they did not need it, then it's not helping our patients. So there's approximately 5% of patients treated with ICI that will develop arthritis, and it's a bit later on compared to myositis. It's about 4 months in average after starting immunotherapy, but it can happen earlier on. It can happen up to a year after stopping immunotherapy. And the most frequent manifestation that we see is symmetric polyarthritis that really looks like rheumatoid arthritis. We also have polymyalgia rheumatica with the shoulder stiffness, the hip stiffness, which can rarely be seen with the giant cell arteritis. So it's always important to ask our patient the questions if they have headaches or vision change, scalpalgia, tenderness, to make sure we're not missing something more serious than the polymyalgia rheumatica. And what we often see as well is the patient that have pre-existing psoriasis that can develop psoriatic arthritis when they're started on immunotherapy. So the symptoms that are different from the mechanical symptoms, so the patient will have joint swelling, morning stiffness, it's going to be improved with mild activity and worse at rest. So I think those are, if we ask the symptoms to this patient, those are more indicating us it's inflammatory as opposed to mechanical pain. If they lift their shoulder, they have a bit of a tendonitis, or they had like very bad osteoarthritis in the knee and then it gets worse, those would be more mechanical symptoms. And we can reassure the patients that usually doesn't cause erosions or deformities as opposed to usual rheumatoid arthritis or psoriatic arthritis. And we do the same workup. The inflammatory markers, RF, CCP, ANA, although the patients are more of the time they will be seronegative, but again, we can unmask pre-existing, maybe latent rheumatoid arthritis with ICI. So those are the patients who will be maybe more cautious when we taper the steroids or the immunosuppressive, and we do baseline X-rays as well. So just like the pneumonitis, ICI arthritis is one of the complications that can be chronic. So 6 months after ICI discontinuation, 50% will still have the inflammatory arthritis. We can reassure the patient. Sometimes I use this when they're discouraged of their pain, that this is associated with good cancer response, and we even have some evidence that the longer it persists, the better the cancer response is. So we have our guidelines are currently being updated. Those are the guidelines from EULAR 2021, and I think this is where I don't know like which centers people in the room are working, but at the Jewish we have a very good collaboration between the oncologists and the rheumatologists, and it's our pleasure to see the patients rather quickly to inform and to help guide the diagnosis and the treatment, but the decision to hold or to continue the immunotherapy should be based on the severity of the rheumatic disease, the need of immunosuppressive agents, and the tumor response, the future oncology treatment plan, and also always being a shared decision with the patient. So we always discuss those cases at our tumor board, because as a rheumatologist, I'm not able to make the decision by myself. I always need the oncologist input and see if there's other options for the cancer treatment. So we're happy to collaborate with the oncologist. The first line of treatment is the anti-inflammatory when there's no contraindication. Often our patients are older, some that have kidney cancer, that have only that have nephrectomies, we have to be cautious with. We try to do more corticosteroid injection, try to buy time and to lower the corticosteroid, the systemic corticosteroid for the patient. So I usually start very low, and I prefer seeing the patients a week later and see if they improve than starting too high, as we showed there's many evidence suggesting that the peak doses can be deleterious and impair the ICI efficacy. So that's to be kept in mind if you don't have rheumatologists and you start the treatment. It's always, they usually respond well to like 10 milligrams, 15 milligrams of prednisone. So we usually don't give more than that. We don't have to go with like the 40, 50 milligrams. And also brings other side effects to the patients. And then if they were not able to taper down the 10 milligram, this is where we add the second lines like methotrexate, Plaquenil, and the third line, the biological DMARDs, anti-IL-6, anti-TNF. So this is the guidelines. We don't always do that in the clinic. Sometimes, like I said, we want to be able to continue giving the immunotherapy. We don't have time to wait for methotrexate or Plaquenil to be effective. So this is where we could use anti-IL-6 or anti-TNF earlier on, and we currently have a clinical trial where we're going to look at the efficacy and safety of anti-TNF early on in those that have, in the first 3 months, for those who are refractory or steroid dependent. So if you have those patients, you're welcome to ask us at the Jewish to refer them to us for it, so we could see if we can include them in our trial. It's a Canadian, it's multi-center prospective trial that we just started including patients. And now I'm going to talk about safety and efficacy of ICI in those with pre-existing rheumatic diseases, and I think this is very important for all the rheumatologists, and also for all the oncologists to know that there's no contraindication for the patients with pre-existing rheumatic disease to receive the best cancer treatment. There's for sure a risk of exacerbations when we give ICI to those with pre-existing autoimmune diseases, and they were mostly excluded from the clinical trial, so we're mostly looking at not randomized controlled trials data, but mostly observational data. We know that the risk of reactivating the rheumatic disease depends on the pre-existing disease. So the patients with rheumatoid arthritis, polymyalgia rheumatica, psoriatic arthritis will have about a 50% chance of having a flare when we start the immunotherapy. Whereas those with lupus and vasculitis, it's going to be more around 20%. So the chance of reactivating is not the same depending on the pre-existing rheumatic disease. I wanted to say something else, but and then there was there's a registry that look at safety and efficacy of ICI in patients with metastatic melanoma and pre-existing autoimmune disease. And they show that there is no difference in overall survival with patients with autoimmune disease, though compared to those without autoimmune disease. So it seems like it's safe and also effective. However, when we look at the impact of baseline immunosuppression on survival, this is where we have to be a little bit cautious. So this is just because the time was limited for this presentation, so I'm just presenting this paper, but there's several papers suggesting that when we have immunosuppression at baseline, when initiating immunotherapy, there's altered progression-free survival and overall survival. So this paper only showed the effect on progression-free survival. There was maybe a signal for overall survival, but there's other papers suggesting this as well. So we have to be cautious with the immunosuppressive treatment at baseline for those starting immunotherapy. And so that's why we have published those guidelines just this year, but just last year, now in 2026, just last year in 2025. So this was a work of our research group, the Pan-Canadian CanVio cohort, and we worked really hard and to produce those guidelines. So there was basically separated in different diseases. So there's two parts. The first part is inflammatory arthritis, so rheumatoid arthritis, psoriatic arthritis, spondyloarthritis. So basically for those diseases, we suggest, unless there's extra-articular manifestation, so if you have scleritis, aortitis, gastrointestinal disease, so if you have anything that's extra-articular, we suggest to keep the same immunosuppressive sense as they had at the baseline. If they only have joint and they're well controlled or they have low disease activity, we recommend to try to taper or stop the immunosuppressant. Again, with discussion with the oncologist and with the patient. Like if the patient says, like, there's no way, I don't want to deal with a flare, I don't want to take the risk, then we continue the baseline immunosuppression. But if the patient is, we explain that there could be potential effect on lowering the ICI efficacy, they could decide that they want to stop the immunosuppressive at baseline. And for the polymyalgia rheumatica, unless there's the associated giant cell arteritis, we suggest to taper the prednisone lower than 10 milligrams or to maintain the lowest effective dose to prevent flares. And one thing is certain in the guidelines is that we don't recommend to prophylactically escalate immunosuppressive prior to starting immunotherapy. So the studies have not shown that immunosuppressive at baseline is able to lower the risk of flare. So we're not even sure if we keep the immunosuppressive agent the same, that if we're gonna prevent flares. So we're like a bit in a gray zone. So that's why we came up with those recommendations, but the evidence level is very low and the recommendations are weak. And when we look at more at the systemic rheumatic diseases like scleroderma, lupus, myositis, vasculitis, Behçet, then for those diseases, we thought that the risk is too elevated to cause a flare, especially that they most likely have organ involvement, like they're more like multisystemic diseases. So we suggest to continue baseline immunosuppression, and in the lupus, for sure, to continue the hydroxychloroquine. The sarcoidosis, unless there is extra-articular manifestation, if it's only stage 1 lungs with the lymph nodes, then for this one we suggest to reduce or stop immunosuppressive unless there's organ-threatening disease. And again, the evidence is very low, the recommendations is weak, but after reviewing all the literature, this is what we came up, but it always will be to be discussed with the oncologist and with the rheumatologist. So some take-home messages before taking some questions. So the overlap with ICI, myositis, and myocarditis is associated with increased severity and risk of mortality. The first line of treatment remains steroids, and maybe in a few years it won't be that anymore. And the second line of treatment for those who are refractory, we can use DMARDs like mycophenolate mofetil, methotrexate, biologics, and TNF, IL-6, abatacept, the JAK inhibitors, and on some occasions IVIG and Pheresis. The re-challenge with ICI after ICI myositis, it's not a contraindication. We have to be careful with the monitoring the risk and benefits and discuss to support shared decision-making with the patients and the treating team. ICI, inflammatory arthritis, may persist despite discontinuation and become chronic in up to 50% of the case. Although we can reassure the patient, it doesn't appear to lead to erosive or deforming disease, and at some point it will subside, also associated with better cancer response. Observational studies suggest that ICRs are effective and safe in patients with pre-existing rheumatologic disease. So at the Jewish and other centers, I'm sure the rheumatologists are happy to answer your question if you have a patient with pre-existing rheumatic disease, but one of the take-home message we want to have with these guidelines is that they should be allowed to get the best cancer treatment. And the only thing I haven't mentioned, but of course, if they are on abatacept for their pre-existing rheumatic disease, that will need to be discontinued and switched for another DMARDs, because this really will counteract completely the effect of the immunotherapy. So the use of immunosuppressant at the time of initiating ICI therapy may be associated with a poor tumor response. So I suggest that that you're aware of those recent Canadian guidelines and the multidisciplinary collaboration. I think this is a key to optimize individual care for patients with rheumatic disease prior to starting immunotherapy. So thank you for your attention.